Hello everyone and welcome back to Clinical Cousins YouTube channel. Today we're going to go over how to determine whether your patient has a hemi-block, also known as a fascicular block in their EKG. So we remember from our previous videos that the left bundle branch is really the only branch that has these two main divisions called fascicles. So we have a left anterior fascicle and we have a left posterior fascicle. So what happens when one of these fascicles becomes blocked? Well, we already know that the left anterior fascicle is sort of compact. It's sort of like a single string. So it electrically activates the anterior, the lateral, and the superior aspect of our left ventricle. And our diffuse or more spread out left posterior fascicle electrically activates the inferior and posterior aspect of our left ventricle. Remember, everything we talk about today, we're talking about the left ventricle only. If the left ventricle isn't working, we're not living. So when one of these fascicles becomes blocked for some reason, we don't have that fast activation anymore, and we have to rely on this slow cell-to-cell activation of the left ventricle. So let's see what happens when we have a left anterior hemiblock, or LAH as it's called. So we have blocked the left anterior fascicle for some reason. Let's say that we just cut it. Well, it's relatively easy because this is sort of just like a single string that we have to cut, which means that the left anterior fascicle is a little bit easier to block. So keep that in mind for later. So that means that the anterior and lateral aspects, and also a little bit of the superior aspect of the left ventricle, is going to depolarize using that slow cell-to-cell depolarization. So what will that vector look like? Well, it will start at the interventricular septum, as you can see here in black, and then it will move upwards and leftwards. So this is normally how the fascicle would activate it, but we see that because we have this slow cell-to-cell depolarization, it's a little bit more unorganized. So we have this depolarization vector that's heading upwards and leftwards. So as you can already probably guess, this will cause a left axis deviation in some cases. So we know that left axis deviation from our other videos is on the XY plane, it's going to point between -30 and -90 degrees. So what does this abnormal electrical depolarization vector look like on our EKG? Well, we have to remember the phrase LAH 3, 2, 1. So it's as easy as that, 3, 2, 1. So we're going to have a low RS complex in lead 3. It sort of looks like how V1 would look. We're going to have an axis deviation to the left in lead 2, and we're going to have a huge R wave in lead 1, or at least one that's greater than expected. So to review, how do we determine a left anterior hemiblock? Well, we have an LAH. We're going to see it in 3, 2, 1, meaning we're going to have a low RS complex in lead 3. We're going to have an axis deviation to the left, which can be confirmed by looking at lead 2 as we know in our other videos. And we're going to have a huge R wave in lead 1. It might not be huge. It might be greater than what's expected for lead 1, but this is how we have some criteria that will point towards the diagnosis of a left anterior hemiblock. Okay, that was good. So now we're going to go to a left posterior hemiblock, or LPH. So we need to remember that the left posterior fascicle is harder to block because it's more diffuse, it's more spread out. The fibers are more spread out, they have more collateral circulation, which means that it's harder to block. It's harder to cut all of these little strings. You'd have to have a lot of damage. So because of this reason, the diagnosis of LPH is a diagnosis of exclusion. There are a few of these in medicine. It basically just means that the only possible diagnosis left after ruling out all these other conditions is a left posterior fascicular block, or a left posterior hemiblock. So if this occurs and it's a new occurrence, then it's likely that there's been some pretty serious damage that was done to a large portion of the heart to block the whole left posterior fascicle. So because the left posterior fascicle is blocked, it means that the inferior and posterior aspect of the left ventricle will have to be electrically activated by a slow cell-to-cell depolarization. So this means that the depolarization will move in a normal route, but it will be slower and therefore more noticeable. So we're going to have a depolarization vector that's going to move towards the inferior and rightward. So this is LPH, good. And it's going to move more downwards and rightwards. So we can probably predict that this will cause some right axis deviation as well. So that's an axis that's between 90 and 180 degrees on the XY plane. But the important thing is, how will this look on our EKG? Well, all we have to remember is LPH. Yep, that's all we got to remember is LPH, or left posterior hemiblock. So this means that we have a low S in 1 or Q in 3. Okay, yes. So do we have a perfect or right axis? Well, if we have a right, then it's going to symbolize that, well, maybe we have an LPH. And lastly, do we have right atrial enlargement or right ventricular hypertrophy? So if we have either of these two, then it means that we cannot diagnose LPH. So let's break that down. We know this is a diagnosis of exclusion. It's pretty rare to see on the EKG, but how do we diagnose LPH? LPH, so low S in lead 1, or do we have a low Q in lead 3? Yes, well, this is a step in the direction of LPH. We can continue on in our diagnosis. So do we have a perfect axis, or is it right axis? So if it's right axis, then we know that we're going to move a step closer towards diagnosing our LPH. Now, this is the big one. This is the big test. This is what usually rules it out, is do they have right atrial enlargement or right ventricular hypertrophy? Now, this means, do they have peaked P waves in leads 2 and 3 that measure more than 2.5 millimeters? Okay, yes, if they do, we cannot diagnose this. Or do they have a first half of the P wave in lead V1 that is greater than the first half of P wave in lead V6? No? Okay, well, that's good. Well, do they have right ventricular hypertrophy? Meaning, do they have an R wave that is greater than the S wave in lead V1? Or in other words, do they have an RS ratio in lead 1 that is greater than 1? Well, no, then we can finally have our diagnosis of a left posterior hemiblock. Now, some of you may be familiar, I just triggered in your mind the S1Q3T3 pattern that indicates pulmonary embolism. So if your patient has a new onset of this finding, just a quick reminder to check them for tachycardia and other physical signs of pulmonary embolism. Perhaps the testable material is really pink frothy sputum. So another fun fact about LPH is that if it's present in an EKG, we have to compare it to see if it's a new occurrence. So if your patient presents with a new left posterior hemiblock, then suspect the worst. Monitor your patient for an acute myocardial infarction. But if this is an old finding, then take an actual look at your patient as always and be sure that they're doing okay, but continue to monitor them as well. So if we take a step back, what have we learned here today? Hemiblocks are blocks of half of the left bundle branch. So meaning that the fascicle is blocked, not the actual bundle branch itself. So a hemiblock is the block of a fascicle that innervates the left ventricle. So we know if the left anterior fascicle is blocked, then we know that we will likely see a left anterior hemiblock in 3, 2, 1. This means that we will have a low RS wave in lead 3. We will see an axis deviation to the left, which we can confirm by looking at lead 2. And we will see a huge R wave in lead 1. Now, if we see the more rare and sometimes the more dangerous left posterior hemiblock, we know that we're going to see a low S wave here in lead 1 and a low Q wave in lead 3. If we say yes, then we move on. Do we have a perfect or right axis? Well, if we have a right axis deviation, then we know that we are going to continue on with our diagnosis of left posterior hemiblock. And lastly, this is the one that rules it out most times, is do we have right atrial enlargement, either by the normal P pulmonale criteria or the intra-atrial conduction delay criteria, or do we have right ventricular hypertrophy? So if we don't have either one of these, then we can say that we finally end up at left posterior hemiblock. So remember, the important thing is to use the 3-2-1 criteria, and to remember that left posterior hemiblock, if it's new, it's more dangerous, and to remember that it is a diagnosis of exclusion. So please remember that they must have a low S in 1 or Q in 3. They must have right axis deviation, and they cannot have right atrial enlargement or right ventricular hypertrophy, because this will rule out LPH. So as always, thank you for taking the time to learn with us today, and remember to like and subscribe for more content.